So we continue our series on anemia, and today we'll be doing a more specific topic, sickle cell disease. And you remember when we were talking about the types of anemias, we talked about hemolytic anemia, and then we said under that you could have sickle cell disease as being one of the causes for hemolytic anemia. That's a very, very important topic because we'll be seeing that as well. We'll be seeing lots of cases of sickle cell disease when we start practicing. I'm sure we are even seeing a lot of cases as stands now. So, I mean, there are more complicated aspects of sickle cell when you want to go into the genetics and all. I've tried to simplify it, and then so always the focus is going to be on the pathophysiology, clinical features, as in what your patient is going to come to you and tell you is wrong with him or her, and then what you as a clinician will be able to pick up, okay, and then how you'd be able to investigate a patient you suspect is having sickle cell disease. And then, of course, we can't do all that without being able to manage. So we'll try and touch on management of sickle cell disease as well. Okay. The thing is that as the world advances and then you have more people going into genetic study and all, there are new advancements, new technologies for management of sickle cell. So it keeps changing. But I mean, until the technology gets into our system here, we will keep doing what we know how to do best whilst we wait for something amazing to happen to us so that we can also be able to manage sickle cell as they are doing outside. Okay. So basically, sickle cell disease is just a group of blood disorders, okay? And this time around, the focus is on the hemoglobin of the red blood cell, and specifically the beta globulin chain of the hemoglobin of the red blood cell. So you remember during our lecture series on anemia, we said that once you take the red blood cell, you've got hemoglobin in there, and the hemoglobin is made up of 2 alpha chains and then 2 beta chains. If you have any form of abnormality with this alpha chains or beta chains, okay, in terms of the structure of the chains, or in terms of, should we say, the size of the chain, or in terms of the genetic makeup of that chain, any form of abnormality you have can predispose your patient to having issues relating to the red blood cell. With respect to sickle cell disease, the issue here has to do with the beta globulin chain. And what is happening is that the beta globulin chain is made up of a collection of amino acid residues. So these amino acid residues come together, they join themselves together, and then they form the beta globulin chain. Okay, for a normal beta globulin chain at position 6, you are expected to find glutamic acid. So when you take a normal beta globulin chain at position 6, we expect to find glutamate or glutamic acid. Okay, but if by some scientific or genetic process or by some mutation, this glutamic acid or glutamate disappears, and in place of the glutamate or glutamic acid, you have what we call valine, which is also an amino acid. You have valine at position 6 instead of glutamic acid, then you would have a problem. Ideally, we say the normal hemoglobin, we depict it as HbAA, ideally. So whenever you see HbAA, you're expecting that this is a normal adult hemoglobin, HbAA. But when that glutamic acid on position 6 is, exchanged for valine at that same position 6, then the normal HBAA will lose its structure, and then you can have an S forming instead of an A. Okay, so basically that's what happens. So just like genetic inheritance, we expect that a child would take one from both parents. Okay, so a normal, your normal HB from one parent will be HBA. If you take from another parent, it would also be HBA. So these two HBAs have a correct sequence of amino acids. And at that point, what makes it right in terms of sickle cell is at that point of position 6 of the sequence, they have glutamic acid. But in case they inherit another form of the HB, instead of HBA, they inherit HBS from their parents, then the issues start rising. If we go into genetics, we say that the basis of sickle cell is an autosomal recessive. Okay, autosomal recessive here means that if you have just one abnormal hemoglobin chain there, if you have one abnormal gene, so if let's say you have a patient who has normal HBA from the father and an abnormal HBS from the mother, this patient would be AS. It doesn't mean that the patient has sickle cell disease, okay? Because we're saying that the inheritance of sickle cell disease is autosomal recessive. Recessive means that the gene that you've inherited from one person is sort of dominated over by the correct gene, which you've inherited from the other person. So in this case, if a child inherits the HBA from the father and HBS from the mother, the HBA will show a dominating force and suppress the HBS that the child has basically inherited from the mother. In so doing, even though this child won't have the usual HBAA combination, the fact that the child will have HBAS combination means that the presence of the A will dominate and hence give the child some proper function. Okay, so this child now becomes HBAS. However, this child can pass on the S, and if unluckily, the child is getting married to someone else who also passes on an S, then their S's can come together and you have HBSS. Once you have HBSS, you don't have anything there to exert the dominance over the S. So we say that the recessive gene would now come into full effect and then start showing whatever you are supposed to be seeing when you are dealing with HBSS. Okay, so it's a little bit complicated when you go down to genetic studies, but it shouldn't be. Just know that once we talk about sickle cell, because that is what will differentiate you from the other person who is not the clinician, you know the basis of the disease. So once we talk about sickle cell, we are talking about the hemoglobin. The hemoglobin is made up of 2 alpha chains and 2 beta chains. Okay. The sickle cell, basically a patient who has sickle cell would have a defect in the beta globin. Their alpha globin chains are fine, but the defects would be from the beta globin chain. And how does this effect come about? This effect is due to the fact that for a normal beta globin chain at position 6, you need to find glutamate, which is the same as glutamic acid. But once there's a genetic mutation, okay, so what we call a point mutation. So there's a point, a mutation at a single point. And this at this point is called the position 6. Chromosomes have a lot of positions. So at position 6, once you have a point genetic mutation, you would end up losing the glutamic acid, and instead it is replaced by something else called valine. And once you have valine coming in, the whole normal structure of the A will change to an S. But ideally, if you have only one S, you don't expect to have symptoms because the disease is an autosomal recessive. If it was an autosomal dominant, it means just one S is enough to show symptoms. But because it's an autosomal recessive, you are lucky enough and the presence of the other beta globulin chain, which you've inherited from the other parent, once that comes out as normal A, then you are fine. You don't say the patient has sickle cell disease. But if for that patient inherits two S's from both parents, so one from each parent, then would say this patient has sickle cell disease, and specifically sickle cell anemia. We reserve the term sickle cell anemia for patients who have SS. So that tells us that you could also have a mutation at this same position 6, okay? And this time around, what is going to happen is that you are going to lose the glutamic acid, but instead of it being replaced with valine, as you see in the S, it is replaced by lysine. And once it's replaced by lysine, you end up forming a C gene. So this patient would have HbAc when the patient is a carrier, but then could actually have SC if the patient is inheriting one S from the father, or maybe a C from the father and vice versa from the mother, okay? So you could also have C gene developing, and the C is when the glutamic acid is substituted for lysine. So that's what makes the difference. So all these genetic changes that I've talked about occurs at position 6 of chromosome 11. Chromosome 11 is what codes for our beta globulin chain. And at that point of position 6 on chromosome 11, a lot of things can go wrong. If glutamic acid is lost and then valine is substituted, you would have S gene being produced. If glutamic acid is lost and lysine comes in there, you're going to have a C gene being produced. A combination of this can give you SS or SC. However, if you have SS, we say you have sickle cell anemia, which is also under sickle cell disease. Okay, but if you have AC or AS, then we say what? You are a carrier. You're not going to show symptoms, but you can pass it on to your next generation. Okay, so what's the pathogenesis here? Ideally, remember the slides we looked at, we saw that the normal red blood cell was, it has this biconcave shape and all that. So round, should we say round? And then it's more flexible because of its round nature. It's flexible as well, and it's able to move through circulation easily without getting stuck in circulation, okay? But when you have a red blood cell which has the S gene, the problem here is that in the initial stages, this S gene would also have produced red blood cells which have a biconcave shape and is able to move through circulation nicely. But unlike your normal HbAA that is being produced, that even under stressful conditions, they are still able to move through circulation, your HbSS or your HbSC that you be forming would usually be insoluble when you undergo certain stressful conditions. Okay, so varying changes in temperature, infection, excessive exercise, any form of stress would cause it to undergo changes. And these changes would cause the red blood cell to lose its flexibility. So it will be unable to move through circulation. Okay, so eventually the red blood cell will pick up a sickling shape. They start looking like what? A sickle shape. Okay, initially when it starts and then it loses its flexibility, it's able to try and then gain its round state. But persistent stress, okay, persistent trigger factors, which we'll be seeing, once it goes on persistently, eventually it gets stuck and then is unable to, reverse to its normal biconcave shape. So it takes up a sickling shape. And that's why it's called sickle cell disease. The stress causes the cell to assume a sickling shape. This sickling shape is rigid, is not so flexible, is unable to move through circulation easily. And hence, once it starts moving through circulation, it will get stuck in circulation. And when it gets stuck in circulation, you are going to have issues. Okay, so what happens? After you develop the sickling cells, the sickling cells, unlike your usual red blood cells, which can live for about 120 days, have a shortened lifespan. So the sickling cells would die early in circulation, and then the spleen will get rid of them because they've assumed an abnormal shape. They can't live the normal life that your usual biconcave red blood cells will live. So they have an abnormal lifespan, a shorter lifespan. And hence, once you are losing them, definitely your HB is going to drop. So that is actually one of the main reasons why they tend to be anemic, because the body rapidly gets rid of sickling cells, and in so doing, your HB will drop. Okay. Also, we're saying that when the cells assume a sickling shape, they become sticky, they are unable to move through circulation, and hence they are going to block the blood vessels. And it's like having a thrombus sitting in circulation. The sickle cell will do the same thing. They'll clog the blood vessel, and then they block it. They slow down circulation, and hence they cause, they prevent blood from flowing from one side to the other, which would eventually lead to some form of ischemia and then a necrosis as well. Okay, because once that happens, you're going to have tissue ischemia, you're going to have tissue infarction, meaning the tissue will die. Then you have necrosis developing. And whenever you have tissue ischemia and infarction, it comes with pain. And that's one of the main reasons why whenever there's a trigger or they have what we call a crisis state, which we'll be talking about shortly, they tend to have lots of pain. It's basically because the red blood cells have clogged circulation and they are preventing the normal blood flow from getting to the distal portions, and hence there's a reduced oxygenation of the tissues. One thing we also know is, as an adaptation, HBS often would, they will tend to release oxygen more readily to the tissues as compared to the normal HbA. It's done in this way so that at least, even in the state of them being sickled, they will still be able to provide some supply to body tissues. Otherwise, we are going to be losing them every time. If they are binding to oxygen molecules really tight, then we are going to have an issue. So the clinical syndrome, you could have HBSS, HBSC, and then HBAS. We would usually say that HBAS won't include that as a sickle cell disease because the patients here is what? An asymptomatic patients that tend to be carrier states, but they are asymptomatic. Okay, so the main focus is usually on HBSS, HBSC. In some very, very weird and rare cases, you are going to find HBCC. Okay, and if you don't do proper investigations, you would miss the diagnosis of HBCC. You'll come and say, oh, this patient doesn't have sickle cell. But then the patient will be having symptoms classic as sickle cell, but because you didn't do proper investigations, you were unable to pick up the HBCC. Okay, so there's also HBCC. You can actually document that. So we talked about stressful states or stressful conditions that would precipitate the red blood cell from going into a sickling state. So cold weather, dehydration. So when it's extremely hot, if you've got an infection, it's one of the main things that bring them to the hospital. When they stress themselves, physical exertion, emotional stress, mental stress, they have an exams and all that, then they start getting a crisis. Okay, so any stressful condition can trigger the sickling state, a sickling usual red blood cell, which has the S gene to undergo sickling. And once it undergoes sickling, it comes with the issue of a shortened lifespan, which will lead to anemia, and then issue of blocking of circulation, which is going to cause tissue infection. Okay. So moving on, we'll talk about the usual clinical features that the patients will come to you with. So one of the common things is they'll come and they'll tell you they have joint pains. Most of the patients will report with joint pains. Others would also report with symptoms of anemia, which we talked about. They would have headaches, dizziness, palpitations, easy fatigability because their HB is usually low. Okay. Some of them come with severe abdominal pain. Apart from the bone pain, joint pains, they could have a certain type of crisis, which we'll be talking about. And in this case, they come with severe abdominal pain. Sometimes the breathlessness can be that severe that it comes with chest pain. And once you start seeing this or you start picking up this, you should be careful because you could be dealing with a very, very serious condition called acute chest syndrome, which usually kills sickle cell patients a lot. So what will you pick up? Now, a patient has told you about pain, and symptoms of anemia. So you would have to examine and usually look to pick out certain features there from anemia. And you remember we said you look out for pallor by checking the palm, checking the conjunctiva and all that. And then you also examine the sclera of the patient for a greenish or a yellowish coloration, okay, which would say that patient here is jaundiced, okay? So you'd try as much as possible to examine the patient's sclera and then pick up the jaundice. Sometimes you don't even have to look so much. As soon as you see the patient, you can actually see that this patient is jaundiced. Okay, clearly you look at the eyes, you see that patient is jaundiced. And the jaundice in this case is coming or arising from the fact that your red blood cells are breaking down in circulation. Okay, so I mean, at the right time, we do types of jaundice. You realize that mainly you have three main types of jaundice. We say we have pre-hepatic jaundice, hepatic jaundice, and then post-hepatic jaundice. Pre-hepatic jaundice is a jaundice that would arise before the liver. Okay, so ideally you expect that when red blood cells break down, they are going to produce what we call bilirubin. And the liver is what is supposed to get rid of the bilirubin. Okay, so it goes through certain stages and eventually the bilirubin is getting rid of, it appears in our stool and then in our urine. Whenever you have a problem with the liver and the liver is unable to break down the bilirubin because the liver lacks a certain enzyme in breaking down the bilirubin, we say that, okay, this jaundice that you are developing is because the liver is unable to do its work well. So then we'll say you have hepatic jaundice. If maybe the liver does its work well, but afterwards it's unable to excrete it into your GI and then for it to appear in circulation and all that so that you can urinate it or piss it out, then we'll say you have a post-hepatic jaundice. Because after the liver works on the bilirubin and everything, it's supposed to pull it out. It goes through the whole biliary system and then it comes out. If you have any obstruction, if you have a cancer of the biliary system, a stone of the biliary system, which impairs or blocks the bowel from moving all the way to where it's supposed to go, then you are going to have jaundice. And this time around, we say it's a post-hepatic jaundice. So the liver is actually fine, but then the reason why you are jaundiced is that you're unable to deal with the whole bilirubin that the liver is trying to work on. A pre-hepatic jaundice means that the problem is before the liver. And usually once we say pre-hepatic jaundice, we want to say that the red blood cells, there's an excessive breakdown of red blood cells in circulation, and this has produced excess bilirubin, and the liver can't handle all that at the same time. So you have some of the bilirubin appearing in circulation without being breaking down. And once this happens, it would stain your body tissues, stain the sclera, and then the sclera becomes yellowish. Worst case scenario, it becomes very, very greenish. Okay. So sickle cell disease would lead to a pre-hepatic jaundice because of the intravascular hemolysis of your red blood cells. So they can have jaundice, they can have pallor. You look at the forehead, you realize that they have certain classic features when you look at their face. So the forehead looks a little bit bigger, sort of bossed in a certain way. Then they usually tend to have developmental problems with their jaw. So you can see that the teeth also sticks out, even sometimes when they close their mouth or when they talk, you can see that the teeth has a classic appearance. We call that natopathy. Their liver could be big on examination, and their spleen could also be big on examination. And basically, this is because we said that the liver is responsible for, working on your bilirubin. So if you are breaking down a lot of red blood cells, the liver tends to be working a lot. Okay. The spleen is responsible for getting the old red blood cells, abnormal red blood cells from circulation. So if you have a lot of circulating red blood cells, it means your spleen will also be working a lot. And in so doing, the size of the spleen would increase. In children, usually one of the first things they will come with is an inflammation of the hands and then the toes. Okay, so they come with what we call dactylitis, which means that their digits are basically inflamed, right? And this is because of red blood cell that is stuck in circulation. So they have congestion or pooling of blood in that circulation or that particular area. So the hands become very swollen and very, very painful. It's very common in children. Okay. And sometimes too, adults can develop venous ulcers or ulcers around the ankle area when they have sickle cell, because already that area tends to have poor blood flow. So even when you get injured around that side, it takes a very long time to heal because of the bone over there. In sickle cell patients, once the red blood cells block circulation, as I said, you are going to have issues. And then because it's blocked, basically, you are going to have venous pooling, blood stays there for a very long time. The effect is that it will create an ulcer, and then it's very, very, very difficult to heal. Okay, so tend to have venous ulcers. So the next slide is on crisis. Okay, if we say a sickle cell patient has crisis, what do we mean? So basically, when we say a sickle cell patient has crisis, we want to say that the patient is in an acute deteriorating state. Okay, patient is very, very, very sick. And if you don't do anything about it, you are going to lose your patient, because you can have patients who are sick, but then once you see them, you know that they would improve. But once you see a patient who you go ahead to say the patient has crisis, you want to say that the patient is acutely ill and the patient is getting worse, you have to step in. So it's an acute deteriorating state in a sickle cell disease patient. There are various types of crisis. Okay, we'll be talking about that. And then usually it pops up in your exam, so you have to pay close attention to it. So we have vaso-occlusive crisis, and vaso-occlusive crisis is, what's one of the commonest things they will present with. They come with lots of bone pain. And even as I said, in children, they come with pain of their hands, foot, and then it looks inflamed. So basically, what we want to say here is that blood vessels going to the bone area has become occluded because you have abnormal red blood cells sitting in the circulation, sticky, preventing blood flow. So it's become occluded. Hence, you have poor perfusion of these areas of the bone, and this comes with severe pain. So you usually see it in the flat bones. Okay, so your hip area, the bones that come together to form your pelvis, they are flat bones, and then the long bones as well. So the femur, the tibia, the humerus, all these are long bones. So they usually come with severe bone pain. You could also have a sickle cell patient coming to you and will tell you, I don't have bone pain, but when I pee, it's like Coca-Cola. Okay. We know that sickle cell patients already tend to hemolyze because red blood cells will break down. But for you to say there's a crisis, We won't say hemolytic crisis, we'll say hyperhemolytic crisis, because this time around, they are not just hemolyzing like the usual hemolysis we know. They are actually breaking down lots of red blood cells at the same time. Okay, so there's a rapid hemolysis of red blood cells due to an exposure to trigger factors. So we say they have hyperhemolytic crisis. So sometimes they could have an infection or a bad malaria, and the malaria already can cause hemolysis. Then the sickle cell patient is also experiencing hemolysis. So once this happens, they're going to have a hyper form of, or an exacerbated form of hemolysis, which would cause severe anemia. Okay. The next crisis we'll be talking about is what we call sequestration crisis. What does this mean? To sequester means to hold on, to pull. So you could have the sickling or abnormal red blood cell getting pulled into the spleen or into the liver. This time around, when your patient comes to you and you examine the patient, you feel that the liver is big, all right, the spleen is big, which is something normal you see with sickle cell patient. But in this case, you feel that it's not only big, but it's very, very tender. When you touch, the patient screams. The patient has tender hepatomegaly, tender splenomegaly. Okay, once you see this in a sickle cell patient, it tells you that you have abnormal pooling, of red blood cell in the spleen or in the circulation, or the liver. We expect that this red blood cells will be in circulation. However, the spleen has pooled and is holding on to it. Liver has pooled and is holding on to it, and it's abnormally, tender, and then it's large. So you find a tender hepatomegaly or splenomegaly when you are dealing with sequestration crisis. Okay, sometimes people tend to forget about sequestration crisis, and all they think about is vaso-occlusive crisis or hyperhemolytic crisis. Look out for that, and you only pick up that if you examine, because your patient will tell you that, oh doc, my tummy is really hurting and I'm sick. When you touch the liver area, the right hypochondrial region, very, very tender. When you go and touch the left side, you palpate the spleen and you realize that that is also very tender. You could also get what we call anemia. We said that aplastic anemia means that all the cell lines are reduced HB, reduced platelets, reduced WBC. Can have a sickle cell patient getting that, and usually it is also triggered by an infection, commonly parvovirus B19. Once they get exposed to this type of virus, they are able to develop what we call aplastic anemia, which would present as aplastic crisis. So you have a patient who is severely anemic, has infection, and at the same time is bleeding because all the cell lines have dropped. Okay. The last one, which is very, very important, is acute chest syndrome. And usually amongst all this, that will even kill you faster. Acute chest syndrome is a form of more of a vaso-occlusive crisis, sort of. So the blood vessels have become occluded, and this time around, it's more of the pulmonary blood vessels become occluded with this abnormal sticky red blood cells. And once this happens, there's excess pooling of blood in the pulmonary area. There's more of a pulmonary congestion. There's poor perfusion to other areas distal to where the occlusion is. And in so doing, you are going to have some form of ischemia and then a possible infarction developing. So acute chest syndrome would lead to pulmonary infarction eventually. And once this happens, patient is going to have difficulty in breathing. If you don't see it early, you are going to lose your patient. Okay, so the onus lies on us. Once we start managing a patient who has sickle cell crisis, and we even think this is vaso-occlusive crisis, it's just a bone pain, always think of a possible acute chest syndrome, because the same way you are dealing with a vaso-occlusive crisis, you could have the same thing happening in your pulmonary vessel or vasculature, which will lead to an acute chest syndrome. So once you are managing for your vaso-occlusive crisis, thinking of bone pain and all that, always think of acute chest syndrome and try to prevent it. Do a prophylactic treatment for the acute chest syndrome, okay, which we'll be talking about. So before we move on to investigations, I think the link might drop soon. So what I'll do is I'll drop it, we'll reconnect, I'll take questions, and then we'll do the final parts of the presentation. Okay.
All right, Doc.
Okay.